Well, I am so honored to be joined by our esteemed panel today. And for those who didn't, why don't we go down the row and everybody introduce themselves?
I'm Dan Hagerty.
And tell us where you're from and tell us about your product. And you have a 30-second limit. I say that as a standing joke.
I'm Dan Hagerty. I'm in Spokane, Washington, up in the Pacific Northwest, and have been treating lipedema patients for over 6 years.
Tom Wright, and I'm in St. Louis, Missouri, and I've been treating for close to 20 years, and yeah.
David Amron, I'm in Los Angeles and back and forth to Salt Lake City, Utah, and then we have Arizona with Karen Herbst, and I've been treating lipedema about 28 years.
Okay.
I'm Nadiv Shapira. I'm from the big state of Delaware. Working with Dr. Malik at East Coast Lipedema Center. Started in the end of 2014 to be involved with lipedema.
My name is Boris Volshteyn. I'm in central New Jersey, the home of Big Hair, place where we don't pump our own gas, and Snooki. I've been involved in lipedema for probably 5-6 years, and in contrast to Dr. Amron, I don't travel too much to other places.
I'm Jeff Ditesheim. I'm in Charlotte, North Carolina, plastic surgeon, solo practice. I do all my surgery on site in an accredited operating room.
Each of you have your own microphones. Yes. So you guys are going to use your lavaliers. And so, okay. All right. Well, the first question we want to ask is, just talking about some protocols. And one question that's been asked is that since lipedema has many comorbidities, would you consider screenings like allergy testing for metal sensitivities in skin removal patients or monitoring iron levels in those undergoing multiple surgeries to reduce risk like anemia? Dr. Amron, you want to take that question?
I think the most important thing to really screen for is MCAS, actually. A very, very concerning thing, and we are learning more and more about it. And I think that in surgical patients, something we're really looking at. Most patients see Karen, they get a diagnosis of things, and there's certain protocols. And actually, one of the things on our list to constantly look at our protocols for MCAS patients. That's the most important thing, I think, with allergies specifically. Other than that, I can't really say that other specific allergy testing is maybe necessary in most patients with lipedema. The other thing you asked about is, what was it? Iron?
Metal sensitivities and monitoring iron levels.
I can't really say much about metal sensitivities. Again, I think it's one of those unusual things that we don't screen for. And then following iron levels in patients as related to like anemia and stuff. I think that is important. That's one of the things I kind of mentioned in my slides, that we look at iron levels in patients who we're seeing anemia in, and even before surgery too.
And then a follow-up question to that is how about going ahead and pre-screening those patients to identify unknown conditions?
Such as?
Those same two. Yes, exactly.
I'm sorry, can you repeat the last phrase?
Lost my place here. How about screening for patients for those metal sensitivities, for iron levels, even if they haven't identified themselves as being anemic? So maybe the patient doesn't have.
I think Dr. Volshteyn, Boris, I think you should take that because he's been I've been checking hemoglobins, but he's been doing much more detailed iron studies on if you could.
It's a good question because whenever you see the patients with lipedema, usually it's a constellation of a lot of different things. I would say vast majority of patients have PCOS. We've seen a lot of patients with Hashimoto's. I think there's a strong autoimmune component. A lot of them have gastrointestinal issues. Maybe there's some Crohn's components. But if you take a look at a lot of them are kind of autoimmune. And I wonder whether a component of lipedema is also autoimmune to an extent. The question is, how much can you technically test? And sometimes over-testing really does not produce any more positive results. It just creates more confusion. So knowing that I'm a plastic surgeon, I'm not really an expert in autoimmune diseases, the information that I can derive from it is somewhat limited. So my point is I'm focusing on things that can provide additional safety to the surgery. And I would have to say that a significant component of the remainder of the testing should be done by the people who manage the condition medically. So yes, I think the benefit of anemia should be tested. I think perhaps transferrin levels, the iron binding capacity could be tested. But would I go beyond that in a preoperative period? Probably not, unless there's a comprehensive treatment center for lipedema, and I think Dr. Amron has probably the one that's closest to that.
Well, thanks. I don't want to take up all the time here, but I feel like I missed something important. You know, it's something we're looking at with Karen Herbst. I mean, why I began this diagnostic and preventive center is to really bring a whole medical component of how to manage patients. A lot of it is peri-surgically too. You know, we identify patients who really have to see her before surgery, and then other patients that we recommend seeing her. And they're really two different things. Certain patients we know have high inflammatory states. We want to see Karen because, again, we're surgeons. You know, we're not the best at looking at all these things. Karen digs deep into it. So I think if you can align yourself with a good medical doctor to then carry out a lot of these things, which we're not really, the best people to do that, I think that's an ideal thing.
Okay. The next question, I'm going to open it up to the panel, but the question is for people with high BMIs, does weight loss make it easier for you to target just the lipedema? You want to start, Dr. Hagerty? High BMI.
Yeah, high BMI. I think if the opportunity presents itself to lose some weight, I think that's certainly helpful. I find it allows us to, in a way, better target the lipedema tissue. But I'm also finding that those patients are even in better health. And I'm finding that their peri-surgical process, especially the recovery, is a little bit smoother and getting back up on their feet. And so I find that activity plays a big role, and I'm encouraging my patients to do that. But significant BMI reductions, I guess there's not a specific one that they talked about. We usually usually ask questions about a BMI limit, but I think there's always a potential to make people healthier and to allow us to get more tissue.
Okay.
Do you mind if I chime in as well?
Absolutely.
So I know I'm one of the few that has a BMI limit for surgery. I do limit to BMI under 50, and part of that is just the physical. We have beds and turning the patients on the beds, and just the safety of the patient. It's not, I would never had a patient fall off the surgical table, but would be horrified if someone fell off the surgical table, and these sort of things they are limits. So we do everything. We do dietary counseling. We prescribe GLP-1s. We do everything we can, and also work with other doctors to help them get to that healthier state prior to surgery, if they can.
Can I take on it?
Yeah.
Can you hear me? Okay, first of all, I think that's a very important question. So none of our patients, we take them to surgery immediately after the first interview. I think on average it takes between 6 and 12 months until they get ready for surgery. Ready, it means that going through all the stages of conservative treatment that we had a lot yesterday. But the BMI allow me to take a little bit the opposite approach. Some patients needs to be operated because they have high BMI. And when I follow these patients for over a year, they cannot lose weight. And the primary reason that many times they cannot lose weight is because they're immobile. They cannot move. It's too painful. So if you address your surgery to the critical area, they can start to be more mobile, go around, then they will start to lose weight. So I don't have limits on BMI, but it will direct me how I will address them. But I don't think BMI per se should be a reason not to operate on patients.
I just wanted to make a quick comment, if you would. About 20 years ago, we were doing Journal Club conference, and there was an article that proposed to do liposuction of the patients before having bariatric surgery. And initially, you'll think it's absolutely crazy idea. But if you take a look at the article, and I haven't seen it since, but the idea was that when patients have bariatric surgery, they lose significant amount of white fat or yellow fat. And it's very difficult to lose intra-abdominal fat. The concept the authors had was, if you do liposuction, not high volume, just liposuction, which apparently somehow changes the way the mobilization of fat happens, after bariatric surgery, predominant weight loss occurs intra-abdominally. And it was 20 years ago, and I think at that point we did not understand lipedema. I personally did not know anything about lipedema. And during our journal club, our boss was very skeptical about it. But 20 years later, actually, you start thinking about it, and it's possible that by performing the cutaneous lipedema surgery, not necessarily in high volumes, changes the way the hormones work, and perhaps they promote the brown fat mobilization.
And a follow-up to that is Dr. Wright, you talked about the reasons for your BMI limit. Does anyone else have, and well, Dr. Ditesheim, how about you? What do you have BMI limits?
So I think we're in an age where we have the option of GLP-1 drugs. And in my own evolution, which I talked about yesterday, when I see a woman at a high BMI, which for my office would be, let's say, over 250 pounds, there is a very good medical option with GLP-1 drugs and elimination diet to lower that weight. And I've seen this many, many times now in the last 6 months, in the range of 80 to 120 pounds weight loss. If a woman came to me and said, would it be safer for you to do surgery on me at 120 pounds less than where I am now? Yes, absolutely. So if we have a modality that we can use before surgery to make the surgery safer, that seems to be a non-issue. That should be something that should be part of every person's discussion with their surgeon before surgery.
Okay.
Can I just say something?
Absolutely.
BMI?
Go ahead.
So BMI, I have this, this thing with for many, many years. I don't like the BMI. I haven't liked the BMI. I don't respect the BMI. If I looked back when it was designed, the early 1800s, never to be used in medicine, and all these studies come out showing this thing against BMI. BMI doesn't make sense to me because it's looking at height and weight and putting people into categories. I think it's done the lipedema community a huge disservice with things. Many of these patients have been qualified with high BMIs for things like bariatric surgery with missing the diagnosis of lipedema. I think in many patients it prevents them from moving on with surgeries or orthopedic surgeries, which are important just simply based on the fact they have high BMIs. Now that said, I for years did things before GLP-1s and MCAS, which has now entered into things in terms of trying to understand patients, and I think a lot of what was said, there's a lot of good points that were brought up. But for many years with these patients with high BMIs, I agree with Nadiv, you have to go in. They've done bariatric surgery many times. They're suffering, and they're trying to lose more weight and bring your BMI down to make who feel comfortable? The surgeon feel comfortable over things? So you got to go in and start making improvements and decongesting areas on these patients. And I've seen it over and over and over and over again. Now with GLP-1s, I think it's an interesting consideration. Karen and I talk about this with a chicken and egg argument. What should really come first? I want to get in there. I want to decongest, remove fibrous areas, get them going with things. But we are on higher BMI patients, seeing her, checking for inflammatory states, using them primarily as an anti-inflammatory thing, screening for MCAS. And so now, things have changed. I think that GLP-1s should be considered in many patients prior to surgery to lose weight or calm them down.
Shane, one more quick point, if I may. let's assume a patient weighs 355 pounds, and we have many patients like that. Let's assume she loses 80 pounds. She's got to 280. But if she still has the remaining painful fat between the knees and she cannot move because of the pain, I think we have to operate on her to have the right strategy, the right plan, but get her mobile.
I think that in all safety, and Boris and I think would agree on this, he does all his surgery at the hospital on very high risk, very large patients, and has great experience and great results. Not all lipedema patients are the same. So it's important for each woman to know, what is my risk? Because everybody wants to have an improvement in their symptoms, in their mobility, pain, swelling, so on. But most people do not know what their risk is when they walk into the surgeon's office. So if you're assuming, oh, I'm just going to have some liposuction, well, that may not be true. And it might be, as Dr. Amron says, that there are MCAS issues to address, and there are other medical issues, as we were saying before. You need to know, what is your risk? Should you be operated on in a hospital, or is it okay to be operated on in a clinic? And if so, how much fat can be removed, and how much fat do you need to be removed? That's a dialogue between you and the surgeon to understand, how can you be helped with surgery? But not every patient is this exact same.
Absolutely. Well, let's shift gears a little bit. Let's talk about Derkham's disease. What are, and this is opened up to all of you, what are your experiences with treating patients with Derkham's disease, and what are your techniques for working with patients with Derkham's disease?
Boris? Oh, sorry.
Well, I don't want to jump it in.
My experience is somewhat limited. If your only weapon is a hammer, after a while, everything starts looking like a nail. So in my mind, I'm a surgeon. I'm not very good at medical management, and I'm not trying to embark on it. I had several patients that had very severe Derkham's disease on the anterior chest wall. I do a test area about my palm wide. I do very aggressive liposuction right on top of the muscle. I put a little breast retractor with a light so I can see inside, make sure I removed as much of those little lipomas as I can. And if the patient demonstrates improvement, then I offer the patient the opportunity to have the area treated, because I do not think it's a reliably consistent result. That being said, I have probably half a dozen patients that had the good results. On the other hand, they say one of the best tests of success of the surgery is a long-term follow-up, and really all of those patients disappeared. Either they're happy and they're living their life, or they're unhappy and living their life. So I think, in my mind, I think it's a reasonable approach, but it's not necessarily an approach for everybody. I have a lady that came in, she has painful Derkham's disease throughout the body, and even it's slightly different than lipedema, but I don't think in her case doing liposuction of everything in the body is really practical. So I think more priority of the management of Derkham's disease is actually medical rather than surgical.
So I can just talk about Derkham's. So first of all, Derkham's is tough. It's a tougher condition than lipedema in general. Secondly, you got to make sure you're properly diagnosed, because Derkham's is difficult to diagnose clinically many times, and I've seen many patients with lipedema who've just been diagnosed with Derkham's by somebody because the patient had some painful nodules or probably lipedema nodules. So you want to get your Derkham's really accurately diagnosed. It's an important thing. I do think that the medical management and a lot of things we'll talk about today should be optimized completely first, because Derkham's is tough. I do think that surgical intervention is a consideration. I think if patients have not a lot of nodules, lipomas, they should be considered for excision of those lipomas and removing. But many patients have dozens or even over 100 Derkham's lipomas. And I've had experience of about 50 to 100 patients with purely Derkham's. And so what I do in patients like that is I give liposuction the opportunity to make as much improvement as possible. And the way I do it, my whole technique in this and that, break things apart mechanically in vaser and this and that. And what I've seen is this. In most patients, it greatly improves most of the lipomas, and then you leave the ones that have not improved to excise, and you've reduced that patient having to have 100 excisions done. Some patients it didn't improve as much, and I had one patient that it became more painful afterwards in certain areas, and then I went back and excised the lipomas with it. But so when there's a lot of Derkum's lipomas, I think it makes sense to try liposuction first in a proper way.
Does anyone else have anything to add?
I may add something. First of all, I'm still trying to clarify in my own mind what is Derkum's. I remember Karen Herbst told me about 8 years ago that Derkum's is actually, it's a spectrum. It between one end that you have like multiple tiny nodules, to the other side that you have these solitary, big, painful nodules. So I don't know where we stand. So I call it lipomatosis dolorosa, but I can tell you in my experience, most patients with lipedema, when they pass the hand over the legs, the inner legs, or many times the arms, they feel nodules underneath. And I can tell you another thing, that I started to measure the threshold when they start to have the pain. And the nodules are more tender than between nodules. So to me, it's Derkum's. Now what I started to do about 2 years ago, I put them on 2 supplements that actually Anne told me about, that I put them on nattokinase and streptopeptase. These are 2 supplements that help to break down protein. And I noticed that after that, the nodules are squishier and many times less tender. And I think then they are more amenable to be removed when you come with your suction, with the suction, try to remove them. And so far I had a good experience with that.
Okay. Let's talk a little bit about compression after surgery. What are your individual protocols for patients to begin compression after surgery? We'll start with you, Dr. Hagerty.
I think compression is critical, and I'm kind of a stickler with it. My assistants and I get the patient into compression while they're still on the table once it's done, and then it stays on for a while, usually a couple of weeks. And where I trained, we get concerned about lymphatic congestion, so I think it needs to be integrated well with lymphatic massage. But also, we don't want the tissue sagging, not only for cosmetic reasons, but to support the lymphatic system. So I encourage patients to stay in it pretty much 24 hours a day for the first couple of weeks, and then we start rotating garments out to get optimal healing. And I feel that gets us good results.
Okay. And a follow-up to that is why use kind of the off-the-shelf or the liposuction garments that are used for cosmetic patients when often they don't fit very well for lipedema patients?
Yeah, I thought it was interesting. We had a discussion. It was either today or yesterday. Someone was talking about proper fitment for garments, and I completely agree. I choose to stock a variety of garments in my clinic, and then I fit them specifically for each patient because, again, I agree, fitment is key. And since we're doing all this work and effort to try and make an impact on this process, this is such an important part of that process. I can't leave it up to chance. So fitment is key. And there are garments that are out there available from different manufacturers that are more designed towards the shape of lipedema, and I think they can be leveraged.
Okay. How many of you have patients use custom garments or request that the patients have a custom garment made for their post-surgical care?
Sometimes I'm selective on that. Many more times it's off the shelf. Yeah.
I just feel there's too many qualified MLD therapists out there, so I prefer to stay quiet. No, I'm joking. It's the whole compression garment thing. I continue to learn from it. It's one of the daunting areas that you realize when you get involved in lipedema that you really don't know a lot about. So, and I'll tell you one thing, I really trust my lymphatic therapists with things. I let them take the lead in terms of a lot of protocols we have, but generally our patients, in fact, not generally, almost always do 3 consecutive days with our therapists. There's bandaging, wrapping go on for a minimum of 3 days. They use compression garments that we provide them. They're typically not custom compression garments. They go back home, they continue MLD therapy like I talked about. Compression pump is restarted again in 3 to 4 weeks. We evaluate the person at that point. Is there a need for longer compression protocols and garments or advanced therapy like bandaging and wrapping?
And I'm going to add to this discussion too. When do you begin? What are your individual protocols for beginning MLD after liposuction?
So, if I can take this. So, I think that one thing that could be really helpful for lipedema patients is to know, okay, do I need a custom garment or can I get an off-the-shelf garment? Can I get the garment from Amazon or do I need one of those from the specialty boutiques? And if I am looking for something, do I need flat knit or woven knit? And I think that those are the questions that come up and create a lot of confusion because a custom garment from Germany will cost $800 to $1,000. That's a lot of money. But a flat knit garment from a company that manufactures in the United States could be $250 and might be as effective or more effective. So this is the kind of information that we need to know in order to be able to recommend to patients, this is what we want you to do. I think the compression and the MLD, which we start early, probably all of us start in the first 2 days after surgery, 3 days, it's really important to see this whole pre and post-op plan as something very important. What I've noticed is that if we tell patients, well, we want you to have compression, they will go to Amazon and get a cheap garment because no one said you need to have this garment. Same thing with post-op. If we don't give a clear post-op instruction, then it's like, you've had the surgery, I'm done, which is not the case. And I think none of us would suggest that. But having a clear protocol for how long you should wear the compression, when should you start MLD, when should you start the pump for each patient, and then seeing the patients early in the first week to know that they don't have a tremendous amount of swelling, knowing what the legs or the parts of the body that you've operated on should look like so you know that they're on the right course.
Oh, right. Anybody else have anything to add to that? Okay.
I can tell you what we do. We use Mirena garment as a base, and then we put Juzo wraps on top. A lot of my patients have higher BMIs. They have bodies that are very difficult to adjust standard garments for. The issue is that we see is that whenever we do liposuction of the legs, usually the most difficult area to compress are the hips, and none of the garments stay, unfortunately. So we are actually thinking about going toward custom garments. We realize it's an expensive proposition, and we're hoping that maybe we'll get some help from the insurance. But that's where we're at. I think we have a stable approach, but it can always be better. And talking about MLD, we start doing MLD at about a week. We also recommend patients starting pumping in a week at the low setting of about 20 millimeters of mercury. But probably after talking, we maybe need to start it sooner, maybe 2-3 days out.
A few other points that are important. There are some women, I know, who cannot wear compression pre-op because it's too painful. That has to be taken into account because you can't tell them to go and do compression garment if they can't put it on without having discomfort. Second is the garment has to be something that can be put on by the patient and covers the foot so that you don't have irritation at the base of the ankle. And if I see patients that have very large lateral thighs, I will treat that first with whatever area I'm treating so that they can do compression, because otherwise they're only going to be able to wear above the knee, which won't be as good. So that has to be woven into the treatment plan.
I want to make a comment. Number one, I believe, I may be wrong, and the therapist can maybe clarify. I think if patients have, if the swelling is too painful to wear compression, my interpretation, they are not adequately decongested. Patients are adequately decongested can wear compression. I've never seen one that cannot wear compression if they're adequately decongested. Now, after surgery, we use what we are using. We are using the Marina because it's easy to put. They have a zipper on each side and much easier to put on. And we do use lower legs wraps. We are using the Cool Flex because when they walk, that helps to pump the fluid away.
I'm just happy to see all these questions about not just the surgery itself, but all the things around the surgery, because it's really important.
Absolutely. And a follow-up question to that is how do we recommend to patients to be able to navigate when they get perhaps contradictory information? And from maybe your therapist that they see while they're visiting you, and then they go home, and then there's and the therapist that they have at home has a different type of protocol. So how can we improve that for our patients?
I think that's really important. We have direct communication. We refer out. We have in each area around most of the Midwest for sure. We know the therapist. Every time we find a new therapist who sees a patient, we reach out to them and ask them and make sure they understand they're very grateful. The therapists are so grateful that they're included in the thing and that they know what we want and they can be on the team together. So that's really important to include them and we have a liaison that reaches out and stays in touch with them, and I think that makes for better care.
I agree. I've reached out to therapy offices in our area and have actually done some seminars for different groups to inform them about lipedema and personally discuss with them just the surgical process and the post-surgical expectations. And I think that smooths that out. I also provide some guidelines, some written guidelines that the patients can go to their therapist for. And then ultimately, I also encourage the therapist to call my in-house therapist and sometimes have a discussion, and they can speak the language. And that seems to work really well.
Again, I've learned my lesson with this too, that just doing the surgery and trusting that MLD therapist outside is going to do a great job just doesn't work. And so what we do is we gather in every state therapists that we trust and have relationships with. We make sure that our therapists in-house are communicating with those therapists, because ultimately it's our responsibility to our patient when things, you can't just expect them to go back, because commonly problems will occur, especially in advanced patients where you really need the therapist's help on those advanced patients, and they're not doing the right thing when they're causing problems. So
we have to remember that the MLD patients have to pay out of pocket. It's not covered and can be quite excessive. So many of my patients, they don't get MLD because they don't need. I communicate with them. I see them a week after that, 2 weeks. If they're remote, I do a FaceTime with them, look at the legs. If they need it, then I communicate with the local therapist. If they don't, keep going with the compression, and they're doing well.
I'm hearing that we need a standard of care for post-operative management of patients.
There's a lot of standards of care. I mean, so many different areas.
They have to pay out of pocket. It's expensive.
Absolutely.
Go ahead. I think that, with all due humility, it's a learning culture. I came to this meeting last year to learn. I learned a ton, and I'm still learning so much. I think patients that are learning are trying to figure it out as we're trying to figure it out. And So if you've come up with information or anecdotal experience that said, hey, I've been using this, or I've been looking into this, and this is a way that has really worked, I think it's really encouraged that feedback to say, okay, maybe next year we can come up and say, okay, this is going to be how we should do post-op compression, because these patients do so much better than any other patients. And if we know that, then great, everybody benefits. But it's a dialogue between the patients and the therapist and the doctors.
Absolutely. Well, we could actually do probably a whole half day on nothing but Q&A for the surgeon. So it is time for us to go ahead and wrap up. I want to again thank all of our panelists for joining us here today.